Welcome to the Deep Dive, where we take the information you've gathered, your articles, your research, your notes, and really unpack it to help you get truly informed. Today we're diving into a topic that's, well, it's pretty crucial for understanding modern healthcare challenges, MRSA. You sent us a really detailed set of notes on methicillin-resistant Staphylococcus aureus. And our mission is simple: to go through your material, pull out the absolute highest yield information, clarify the connections, and maybe find ways to make it stick, especially if you're tackling this for revision. Think of this as your guided tour through the essentials of MRSA, straight from your sources.
That's right. MRSA is a classic example of, well, bacterial adaptation, and it's a major focus in infection control. Understanding its characteristics, spread, and management is fundamental. Based on the notes you've shared, we'll build a clear picture section by section. Okay, let's unpack this. Starting with what we're even talking about. What is MRSA at its core?
Okay, my material defines it as a strain of Staphylococcus aureus that's resistant to multiple antibiotics. Is that the main thing to grasp?
Absolutely. That's the absolute core concept. It's S. aureus, a very common bacterium, but it has acquired resistance. Specifically, it's resistant to methicillin and that entire large family of beta-lactam antibiotics. We're talking penicillin, cephalosporins, carbapenems. This resistance isn't just a technical detail. It's the reason MRSA infections can be so difficult to treat compared to regular S. aureus. It fundamentally changes our go-to weapons, you see.
Right, and regular Staphylococcus aureus itself is something many of us carry around without even knowing it, right?
Precisely. Yeah, about 25 to 30% of healthy people are colonized with S. aureus, often living harmlessly in the nose. MRSA colonization is less common, maybe 1–3% of the population, and like standard S. aureus, it's usually asymptomatic unless it finds a way into the body or, the person is immunocompromised.
Okay, here's where it gets interesting. The notes mention it used to be mostly a hospital problem, but now we hear about community-acquired forms too. How did that shift happen?
That's a critical point from your notes. The genetic element that gives S. aureus this potent resistance, the mecA gene, which basically tells the bacteria how to build a cell wall that beta-lactam antibiotics can't break through. That's been present in hospitals for decades, leading to healthcare-associated MRSA, or HA-MRSA.
Okay.
But starting in the late 1990s, genetically distinct strains emerged in the community, known as community-associated MRSA, or CA-MRSA.
Oh, I see.
Yeah, these strains spread differently and can affect younger, healthier individuals. It really broadened the scope of the problem.
So knowing what it is, how does this stuff actually spread? From person to person or place to place?
Well, based on your material, the primary route is contact.
Contacts.
Direct skin-to-skin contact is a big one, but also indirect contact, touching surfaces or objects that are contaminated. Think about it. Staphylococci are pretty tough bugs. They can survive on environmental surfaces, in dust, on clothes. Your notes mention shedding skin cells can contribute, and activities like bed making might briefly aerosolize particles, but overwhelmingly it's about physical contact.
Got it. And just to clarify the cause,
Yeah.
the cause of an MRSA infection is still the S. aureus bacteria, but the problem is the resistance it's picked up.
Exactly. The etiology, the cause of the infection, is the bacterium, Staphylococcus aureus. But the etiology of the resistance itself is the acquisition of those specific genetic elements, like the mecA gene, that make it resistant. It's the same bug, but it's evolved a defense mechanism.
Okay, right. Let's dive into who is most at risk, because your notes have a pretty comprehensive list, and it breaks it down into those healthcare-associated and community-associated risk factors. This seems like a really high-yield area for revision.
It absolutely is, and the distinction is crucial. For HA-MRSA, the picture that emerges from your notes is really about vulnerability and exposure within the healthcare setting. Who's already sick? Who's spending a long time there? Who's had procedures that break the skin barrier?
Yeah, so things like being elderly or debilitated, having a chronic illness, these make you more vulnerable.
Yes, definitely. Anything that weakens your body's defenses. Then there's the exposure side. Long hospital stays, especially over 30 days, being in a nursing home.
Right.
Having invasive devices like central lines, IVs, catheters, or needing things like sputum suction or dialysis.
Okay.
Any kind of open wound, surgical or otherwise, is also a clear risk because it provides an entry point for the bacteria.
And I see a history of MRSAs listed, which makes sense. And recent hospital stays or surgery. What about antibiotics? I saw that mentioned.
Yes. Antibiotic use is a significant risk factor. It seems counterintuitive, right?
A bit, yeah.
But using broad-spectrum antibiotics can disrupt your normal bacterial flora, the good bacteria, allowing resistant organisms like MRSA to sort of take over and thrive. Your notes specifically highlight cephalosporins, fluoroquinolones, and macrolides as being associated with increased risk of MRSA. And your notes also list HIV positivity, especially in young males with recent incarceration, under HA-MRSA factors, which points to specific vulnerable populations within that healthcare context.
Wow, okay, that's quite a list for HA-MRSA.
Yeah.
How does that compare to CA-MRSA risk factors? They feel like they apply to a different group.
They really do. CA-MRSA risks, according to your material, are much more about close contact and skin breaches in settings outside of traditional healthcare. Think of crowded living conditions. Activities involving regular skin-to-skin contact wrestling is a specific example, given
Right.
having a history of recurrent skin infections or sharing items that touch skin, like towels or razors, that sort of thing.
So prisons, IV drug use, prior incarceration, antibiotic exposure again.
These all come up under CA-MRSA too.
Exactly. It highlights how this bug can get around in different environments. What stands out to me when looking at these lists together is how clearly they map onto the likely transmission routes.
Yeah.
HA-MRSA risks center around the invasive procedures and vulnerable patients in hospitals.
Makes sense. While CA-MRSA risks are more about close physical contact and skin breaks in community settings. Same bacteria, different context, dictating the risk.
That distinction between HA and CA risk factors is definitely a key point to remember. Maybe for revision, like you said, you could try visualizing the two different settings. For healthcare risks, picture that vulnerable patient in a hospital bed, tubes, lines.
Exactly.
And for community risks, maybe crowded places, sports teams. That close contact idea.
That's a good way to anchor it. Okay, so we know what it is, how it spreads, who's at risk. How does it actually cause disease once it's colonized someone or gets into the body?
Right, the pathophysiology.
Yeah. Your notes describe the basic path. It starts with colonization, often skin or nose. From there, it needs an entry point, a break in the skin, maybe a surgical wound, an opening from an invasive procedure.
Okay.
Once inside the tissues or bloodstream, the bacteria multiply. They produce various toxins and enzymes that directly damage tissues, and that leads to the inflammation and the signs of infection we recognize.
And that means it can cause a whole range of infections depending on where it gets in.
Precisely, yeah. Because it's still S. aureus at its heart, it can cause many of the same types of infections as susceptible S. aureus. Your notes list common ones. Skin and soft tissue infections, think painful abscesses, boils, surgical site infections, pneumonia if it gets into the lungs, bloodstream infections, which can be very serious, and even bone and joint infections.
And the symptoms are the typical signs of infection you'd expect in those areas: redness, swelling, pain, pus, maybe a fever.
Yes, exactly. And that's the challenge, isn't it? Clinically, an MRSA infection might look identical to an infection caused by regular S. aureus or even other bacteria. You can't tell it's MRSA just by looking at it, which is why diagnosis is so crucial.
Okay.
And that leads us perfectly to the differential diagnosis. When you see, say, a skin infection, what else might it be besides MRSA?
Well, my notes mention other bacterial skin infections like cellulitis, that's spreading skin infection, and pitigo, those crusty sores.
Right. Very common differentials. And this just highlights the critical need for investigations. Clinically, an abscess caused by MRSA might look exactly like one caused by a susceptible S. aureus or, different bacteria entirely. The only way to know for sure it's MRSA and therefore how to treat it effectively is through lab testing.
Right. Okay. Speaking of the bigger picture, your notes provide some specific epidemiology data for the UK. What's the situation there? Is it still a huge problem?
Well, your material indicates it remains a significant concern in the UK healthcare setting, definitely. But importantly, rates have actually decreased significantly over the past couple of decades.
Oh, okay. That's good news.
It is, largely thanks to intensive infection control efforts.
Yeah.
The carrier rates you mentioned earlier, about 30% for S. aureus, and maybe 1–3% for MRSA in the general population, those align with many developed countries.
And those UK-specific numbers, 694 cases in 2021, down almost 15%, that really underlines that decrease. And the impact of things like the NHS doing post-infection reviews.
Exactly, those PIR.
And Public Health England tracking data monthly.
They do. It shows the structured approach taken in the UK to monitor and combat this issue. While rates do vary globally, the UK data provides a concrete example of how surveillance and control measures can really impact the burden of infection.
So, given that you can't diagnose it just by looking, what are the key investigations? The notes emphasize rapid diagnosis, especially in hospital.
Absolutely critical. The gold standard, as noted in your material, remains sending a specimen like a swab from a wound or blood if you suspect a bloodstream infection,
Hmm.
sending that to the lab for culture and sensitivity testing. This is powerful because it not only confirms if S. aureus is present, but crucially tells you exactly which antibiotics it's susceptible to.
But culture takes time, right? Days sometimes. Are there faster ways?
Yes, and your notes cover this. Molecular methods like PCR,
It's easy, right?
polymerase chain reaction. It can find the mecA resistance gene, confirming MRSA within hours, which is fantastic. There are even automated lab tests and point-of-care tests being developed. These faster methods are invaluable in healthcare settings for making quick treatment and isolation decisions.
Okay, and what about more general tests, like a full blood count, FBC, or blood urine cultures?
Yeah, those are important for assessing the overall picture of the infection. How severe it is, if it's spread to the bloodstream or urinary tract, maybe look for other potential causes. But for specifically confirming MRSA, you really need that targeted culture and sensitivity or a molecular test like PCR.
Okay. For revision, thinking about MRSA investigations,
Yeah.
maybe that CMAP acronym helps. Culture, molecular, PCR, automated tests, point-of-care tests, something like that.
That's a great way to consolidate those key methods. CMAP, I like it. Once you have that diagnosis confirmed, management becomes the focus naturally.
And from the notes, management seems to have two big pillars: treatment with the right antibiotics and infection control.
Precisely. The crucial thing about treatment, as the notes stress, is that the choice of antibiotic must be guided by those sensitivity test results.
Right. You can't guess.
You can't just guess. You have to use an antibiotic that the specific strain of MRSA is known to be susceptible to. Otherwise, you're just, well, potentially making things worse or delaying effective treatment.
Okay. And the list of antibiotics in your notes varies depending on the type and severity of the infection. What are some of the common ones mentioned?
Right. So for milder skin infections, the notes list oral options like clindamycin, cotrimoxazole, or doxycycline.
Okay. Oral options, yeah.
Yeah. If it's a more severe skin infection or something deeper, you're often looking at intravenous drugs like the glycopeptides. Vancomycin is the classic one, or teicoplanin, or sometimes lanzolid.
Yeah.
These agents work via different mechanisms than the beta-lactams, allowing them to bypass that mecA resistance.
Got it. And for infections in specific parts of the body, lungs, UTI, bone.
Your notes provide examples there, too. So tetracyclines or clindamycin for some respiratory infections, maybe glycopeptides for full-blown pneumonia. For UTIs, options include tetracyclines, trimethoprim, or nitrofurantoin, reserving glycopeptides for severe or highly resistant cases.
Okay.
And for really serious stuff, septicemia, that severe bloodstream infection, osteomyelitis, bone infection, septic arthritis, joint infection, endocarditis, heart valve infection, the notes highlight glycopeptides, particularly vancomycin, sometimes combined with other agents like gentamicin, especially for endocarditis.
Right. And there's even a mention of using vancomycin or teicoplanin preventatively.
Right.
Prophylaxis in high-risk surgeries.
Yes, in selected cases.
Yeah.
Trying to prevent the infection from taking hold in the first place in very vulnerable patients is sometimes necessary. But alongside antibiotics, infection control is absolutely non-negotiable. Cannot stress that enough.
Right.
Your notes highlight isolation precautions, scrupulous hand hygiene, that's huge, and decolonization strategies.
Decolonization.
Yeah, which means trying to actually get rid of the MRSA colonization from patients or staff who are carrying it, often using special skin washes or nasal ointments. Screening patients before certain procedures and using contact precautions are all part of a comprehensive strategy to stop it spreading.
What about patients colonized with MRSA once they're home? The notes suggest they can socialize normally.
That's an important point for community management, yes. If someone is colonized with MRSA but doesn't have an active infection and is living at home, they generally don't need special restrictions on their social activities. Standard hygiene practices, good hand washing, not sharing personal items are usually sufficient to prevent spread to others in a non-healthcare setting.
Okay.
Similarly, community healthcare workers just need to follow standard precautions and rigorous hand hygiene.
Okay. So with all of that in mind, what's the typical outcome? How serious is an MRSA infection generally?
The prognosis, the outlook, well, it varies a lot. It depends heavily on where the infection is, how quickly it's identified and treated with the right antibiotics.
Right, the sensitivity-guided ones.
Exactly. And of course, the overall health of the person infected. What's fascinating here is that your notes point out MRSA itself isn't necessarily inherently more virulent or aggressive than susceptible S. aureus. Some strains might be, but generally,
So it's not like a superbug in that sense.
Not always, no. The real danger, and what makes it harder to treat and potentially leads to worse outcomes, is simply that common antibiotics don't work. If diagnosis or appropriate treatment is delayed because you're dealing with resistance, that's when outcomes can worsen significantly.
And factors like existing health problems, say kidney issues or being immunosuppressed, obviously make the prognosis worse.
Absolutely. A weaker immune system or organ dysfunction makes it harder for the body to fight the infection and can definitely complicate treatment.
Which leads us to potential complications if things don't go according to plan. What can happen?
Well, your notes list serious complications. The infection can spread locally, leading to larger abscesses. It can get into the bloodstream, causing sepsis, which is a life-threatening systemic reaction.
Sepsis, right? Very dangerous.
Extremely. This can lead to organ damage and, unfortunately, higher mortality rates compared to easily treatable infections, especially with certain virulent strains or in vulnerable patients.
Okay.
And prevention, as we touched on, is really key to avoiding these complications. Screening high-risk patients before planned procedures in the NHS, for instance, is a proactive step. Identifying healthcare workers as potential carriers just underscores again why that rigorous hand hygiene is paramount. It really breaks the chain of transmission. It's simple, but incredibly effective.
Thinking about this from a revision angle, you could try working through a case scenario, like you mentioned earlier. Imagine an elderly patient, maybe someone with diabetes and chronic kidney disease requiring dialysis who was recently discharged from hospital. They now show up with a painful, swollen area on their leg that looks infected. Based on your notes, what are some significant MRSA risk factors this patient has? What are the absolutely critical investigations you'd want to do right away? And what are the most serious complications you'd be watching out for if it turns out to be MRSA? Running through a scenario like that helps pull all the pieces together.
That's an excellent way to test your understanding, absolutely. So to kind of synthesize it all, what does this deep dive into your notes on MRSA really tell us?
It tells us MRSA is a significant challenge because it's a common bug that's become resistant to standard treatments. That's the core issue. And it's not just in hospitals anymore, it's in the community too, affecting different groups of people with different risk factors.
And because of that resistance, diagnosing it accurately and quickly with lab tests, culture, sensitivity, maybe PCR is essential. Management relies on choosing the right antibiotic based on those sensitivity results, and just as critically, implementing strict infection control measures like hand hygiene and maybe isolation.
Right. Considering how MRSA developed this resistance and then spread so effectively, and knowing that antibiotic resistance generally is such a growing global problem, what might be the next big challenge we face with bacterial infections? And how does understanding MRSA help prepare us for it? That's something to really think about, isn't it?
It really is a sobering thought.
We've covered a significant amount of ground in this deep dive, hitting all the key areas you outlined in your MRSA notes, from the basic definition and spread all the way through to management complications. Hopefully breaking it down like this helps consolidate these points for your revision.
Remember, connecting the dots, the etiology, the resistance mechanism, the risk factors, the clinical picture, the right management, that's what makes this material truly stick.
Absolutely. And if you are deep in study mode, maybe getting ready for something like the MSRA exam, don't forget there are resources out there that can help, like pathomsra.com and freemsra.com, which offer additional support and questions. Thanks for joining us for this deep dive.
Until next time.